hemostasis, and coagulation instrumentation. So we have some assay endpoint detection methods or principles. So endpoint detection methods measure when a biochemical reaction reaches a defined endpoint. Often it's going to be a clot formation or a color change in heme and coagulation. It can be performed on automated or semi-automated analyzers for improved accuracy and efficiency. For detection methods, we have mechanical, which detects clot formation by sensing physical changes such as increased viscosity or clot firmness. Some examples would be a detection of clot by changes in movement or pressure in the sample. Then we have photo-optical. This measures changes in light transmission or absorbance through the plasma as clot forms or reagents react. Clotting causes increased turbidity or color change, which alters light passage. This is common in PT, APTT, and fibrinogen assays. For chromogenic, this uses substrates that release a colored product when cleaved by a specific enzyme. The intensity of the color will correlate with the enzyme activity. Then we have nephelometric. This measures light scattering caused by immune complexes or particulate matter formed during the assay. This is used in immunologic detection such as fibrinogen or D-dimer quantification. Then we have immunologic. This detects specific antigens or antibodies via immunoassays, often using labeled antibodies for quantification. This includes turbimetric and latex enhanced immunoassays for D-dimer and fibrin degradation products. For recent improvements, there are enhanced automation and integration with laboratory information systems. We have improved sensitivity and specificity through refined reagents and detection methods. We also have miniaturization and point-of-care testing devices for rapid bedside results. We use a multiplex assays that allow simultaneous measurement of multiple analytes. For mechanical endpoint detection, so as mentioned earlier, this detects clot formation by sensing physical or mechanical changes in the sample. For the mechanism of how it works, so as a fibrin forms and the plasma begins to clot, the viscosity and resistance to the movement will increase. So the changes are detected by the device that will measure the movement resistance of a probe or wire in the sample, and it will also measure the change in pressure or mechanical motion within the reaction cuvette. This is used in some coagulation analyzers to detect clot formation without relying on optical changes. For photo-optical endpoint detection, we also call this turbidometric detection. This works by a polychromatic light, which is first focused by a collimator and filtered to select a specific wavelength. The monochromatic light is transmitted through fiber optics and forced on the reaction cuvette containing the plasma specimen. As the fibrin forms, the plasma becomes more opaque. This opacity scatters and absorbs light, reducing the intensity of light reaching the sensor. The decrease in transmitted light intensity is measured over time. So the point at which the light intensity drops indicates that there is a formation of a stable clot. This is widely used in PT, PTT, and fibrinogen assays in the automated coagulation analyzers. Chromogenic endpoint detection. So this measures the activity of a specific coagulation factor by exploiting its enzymatic or protease properties. The coagulation factor acts on a chromogenic substrate, which, when cleaved by the enzyme, releases a colored product. The amount of color produced is proportional to the enzymatic activity of the coagulation factor being measured. So we can do a direct measurement. So the enzyme or coagulation factor directly will cleave the chromogenic substrate. The color intensity correlates directly with the activity of the factor in the sample. We can also measure indirectly. So the activity of the factor is inferred by its ability to activate or inhibit another component that subsequently acts on the chromogenic substrate. So the color change reflects the downstream effect related to the factor's activity. There have been some recent improvements in hematology and coagulation assays, always changing, but we have improved accuracy and precision. So its enhanced technologies and better assay designs have led to more reliable and consistent test results. It reduces variability between runs and between laboratories. For random access, it allows multiple tests to be performed simultaneously on a single analyzer without manual intervention or batching. This increases laboratory throughput and turnaround time. For improved reagent handling, there's automation of reagent preparation, dispensing, and storage, which has helped improve consistency and actually has reduced human error. For reducing reagent and specimen volumes, modern instruments require smaller amounts of reagents in patient samples, minimizing waste and patient discomfort. This is especially important for pediatric and critically ill patients that may have a limited blood volume. For open reagent systems, this allows laboratories to use reagents from multiple manufacturers rather than being restricted to just that one kit from the manufacturer. This increases flexibility and cost effectiveness. For reagent tracking, we have automated tracking systems that monitor reagent lot numbers, expiration dates, and usage. It ensures quality control and traceability in the testing as well. For improved specimen management, it enhanced sample handling systems to reduce errors and improve workflow. We have primary tube sampling, so the automated instruments can sample directly from the patient's original blood collection tube, which reduces sample transfers and potential contamination. We have closed tube sampling, where the instruments can draw sample through the sealed cap or septum without opening the tube. This helps to maintain specimen integrity and biosafety. We also have automatic dilutions, so automated dilution of samples and reagents for assays requiring multiple concentrations. This enhances accuracy and saves time. We also have some expanded computer capabilities now, so internal data storage and retrieval. Instruments can store large volumes of test data internally. This enables easy retrieval of past results for review, quality control, or audit purposes. We have programming flexibility, which allows customization of test protocols, calibration curves, and reporting parameters. This enables laboratories to adapt assays and workflows according to their specific needs. We also have instrument interfaces, so there is a seamless communication with laboratory information systems, or an LIS, and the other hospital networks. This facilitates automated result reporting, reducing transcription errors. We also have barcoding, which uses barcode scanning for sample identification, reagent tracking, and workflow management. This improves accuracy and traceability from specimen collection to result reporting. For flagging, so we have automated systems that can flag abnormal or critical results for immediate review by the laboratory personnel, and this has actually helped prioritize urgent cases and has helped to ensure timely clinical intervention. For reflex testing, instruments or software can trigger additional confirmatory or related tests automatically based on the initial test results. This enhances diagnostic efficiency and reduces manual workload. For specimen quality set points, these are built-in checks for specimen quality parameters such as, do they have enough volume? Is it hemolyzed? Is there a clot present? Things like that. These flags specimen, they do not meet quality standards and preventing unreliable results. Flags for instrument malfunction, so automated detection of instrument errors or malfunctions, can also alert operators to potential issues before they impact their test results. Some top priorities of the laboratory for instrument selection is cost effectiveness. So we have to make sure we're always balancing the budget with the budget constraints. We need to make sure we have accurate and timely testing with that. For testing capabilities, we want to look at the ability to perform a wide range of necessary assays reliably. We want standardization, so ensuring consistent, comparable results across different instruments, operators, and time. We're going to look at test selection, so choosing tests based on clinical utility, accuracy, turnaround time, and cost. We want to prioritize tests that provide actionable information for patient care. For the actual instrument selection criteria, we're going to look at, once again, that instrument cost. So what's the initial purchase price and long-term financial impact? What are the consumable costs? So the expenses related to reagents, calibrators, controls, and disposables. Is it reliable? We want it to be consistent, so consistency and performance and low frequency of errors or downtime. How about service response time? We want availability and speed of the technical support and repairs. Maintenance, so requirements for routine upkeep and ease of performing maintenance tasks. We want it to be easy to use. We want it to be user-friendly. We want it to be have a good interface that people can use. We want it to be a good training and have good workflow integration as well. We're also going to look at throughput. So we want to look at the number of tests that can be processed in a given time frame, matching the lab volume demands. For point of care testing, the tests that are included, so the range of tests depend on the type of capabilities of the point of care analyzer. Some common coagulation tests that are performed at the point of care level include the prothrombin time, or the PT, also an activated clotting time, or an ACT, an activated partial thromboplastin time, which is the APTT, and sometimes a thrombin clotting time, sometimes a fibrinogen assay, and sometimes a D-dimer assay. But for the most part in coagulation, you are going to see the PT-INR for the most part. Some instruments available, so point of care coagulation devices range from handheld or benchtop analyzers to the more complex semi-automated systems. Some examples of the point of care coagulation instruments are the hemocron. This is widely used for ACT testing, especially during surgeries and procedures. You have the Coagucheck, which is a portable PT-INR testing device. You also have an iStat, which is a multi-parameter point-of-care analyzer with coagulation testing capabilities. There's also an Abbott Affinion AS100, which includes some coagulation assays as well. So laboratory-based automated and semi-automated analyzers, they're not strictly point-of-care, but sometimes they're integrated in decentralized testing. These can include certain things like a Stego or a Siemens BCS series. You'll probably see a Beckman Coulter and a Sysmex as well.